Hi guys, this is Dr. T from Clinical Medicine with Dr. T. Um, so guys, I want us to talk about history taking. You know, this episode, I don't think it's gonna benefit medical officers and registrars a lot because obviously they know more than I know. But this one is gonna help students a lot, and also some interns. So history taking, as they say that we can be able to diagnose about 80% of our patients from history alone, and then another 15% from investigations, and then the last 5% we still not gonna diagnose them. Even when we have done history and when we have done investigations, we're still not gonna be able to diagnose them. The 80% story is so true, is very true. When you see a patient and you start taking history, you get differentials there, and by the time you go and examine the patient, you already have like strong differentials. Sometimes even you already have the diagnosis, and you examining them is just to confirm the symptoms, the signs that you expect, and also to just see how severe the problem is, and also to check how unstable are they, and all of those things. Yeah, so by the time you go and examine, but you already have a diagnosis, so it's so important. So if history taking can help us in about 80% of our patients, then it means it's something that it's worth talking about. And one of the reasons why I decided to do this, to record this TAT on history taking, is because I meet a lot of students that would see a patient and then come and present to me and say, okay doc, I've seen this patient, can you help me? So I've realized that they make the same mistake. I think it's it's a mistake that everyone does when we are still in medical school. One of the things that they do in medical school is they give us a template of how to take history, and we try to fill in the blanks as much as we can, and we are convinced that if we have filled that template, all the questions in that template, we have taken a good history, and that's not a good history. I'm sorry to say this, but it's not a good history, because you can fill that template from top to bottom and still not know what's happening, and still have no clue what is happening with your patient. So that's one. And number two, it's a good template because it has got a lot of things in it, but the problem is that you need to adjust that template. You need to know what to ask and when. For instance, what I'm trying to say is we need to adjust history taking depending on where are we working. Are we in surgery? Are we in obs and gynae? Are we in peds? Where are we working? And also, if you're someone who's in casualty, you need to know, okay, the patient that is in front of me now, is it a surgery case? Is it a peds case? Is it this? Is it an obs and gynae case? And then you adjust your history according to that, because you cannot take history as if you are in internal medicine when you are in obs and gynae. They will scream at you. And you cannot take history from a pediatric patient as if you are in surgery, for instance. So it depends where you're working. And with the history taking, it's not like anything goes. You need to adjust your history. And let us talk about let me explain what I'm talking about. So I want to give you guys an example. Let's say, let me just get my marker there. So let's say I've got a patient that is let's say I've got a 45-year-old female patient, né? 45 year old 45-year-old female. And before I proceed, let me just explain this. History taking has got a lot to do with how knowledgeable you are, and it's got a lot to do with the amount of experience that you have. You know, there's someone who can write a history that is like a page full and still not find the diagnosis. And then you find someone who just comes in and asks 2 questions and then they get the diagnosis. That's where the knowledge and the experience comes in. Like I always say, as junior doctors, we don't have experience, but the only thing that we have is knowledge. It depends whether you do read or you do study. It depends. So that's the only backup we have. And when you are so knowledgeable, you can compensate in some cases for the lack of experience. I hope you get that. Okay. So let's say I have a 45-year-old female. She comes in, she says, I have a chest pain. When she says I've got a chest pain, as I'm listening to her, I'm not only listening to her, I'm having my own discussion in my mind that what does she have? And when she says I've got a chest pain, I already have differentials. I've got differentials from only the chest pain alone. I've got differentials. My differentials are ischemic heart disease, peptic ulcer disease, costochondritis. Okay, let me write nicely. Costochondritis. My differentials are pneumonia. My differentials are pleuritis. My differentials are pulmonary embolus, or even TB. My differentials are other musculoskeletal problems. Dissecting aneurysm. So I've got differentials. From that, I've got differentials. Now, what she's gonna say after chest pain is gonna make me to take that information and sort of like see, does it fit with any of these symptoms, any of these conditions? Does it fit? It can be esophageal problems, esophagitis, esophageal spasm, esophageal ulcers. You know, the list goes on. And this is not according to any order. I've just put it randomly. So I already have, from just that chest pain, I've got differentials. Now what she will say after this, I'm gonna use that information and plot it or put it against this to decide what am I dealing with here. And if she doesn't give me any information that is gonna make me to decide, I'm gonna specifically ask because I have the knowledge. She's coming with a symptom, but I've got the knowledge. But if you don't have the knowledge, how does this present? How does this present? How does this? Then you won't expect, even if she gives you all the answers, you still cannot put the information into place and come up with a diagnosis. So knowledge becomes very important. Now she says to me, this chest pain, obviously, we're gonna ask about the duration. We're gonna ask about the location. We're gonna ask about relieving, aggravating factors or relieving factors. We're gonna ask about the nature of the pain, stabbing pain, things like that. Ne? It's okay. But now, once she says that my pain is retrosternal, behind the sternum, there are things that I'm gonna be switched on to think about immediately here. So I'm gonna think about, so I said, let's say esophageal problems, facial disorders. So if it's retrosternal, I'm gonna think about one, I'm gonna think about this, I'm gonna think about this, I'm gonna think about this. These are the most common causes of a retrosternal chest pain. I'm gonna think about PE as well. But someone who's got PE, pulmonary embolus, will be less stable than a patient like this. But let's go on. So already I'm thinking about this now, because she said the pain is retrosternal. Okay, so I want to actively roll out ischemic disease from history, if I may put it that way. So I expect her to tell me more about, I want to hear about palpitations. I want to hear about dyspnea on chest pain on exertion, chest pain that is relieved by nitrites or is relieved by rest, is worsened by stress, worsened by activity, might have swelling of the legs, palpitations, things like that. So if that's the case, then I'm thinking about ischemic disease. And then whatever that she's gonna say after that, if she's got those things, I'm thinking about ischemic disease. Whatever that she will mention after this will just be the adjuncts. But already I've got a strong differential that I want to go and examine for and do investigations for immediately. But now if she says I've got a retrosternal chest pain, but this chest pain is worse when I pick up something or when I turn around or things like that, then it's likely to be costochondritis. But if she says, I've been well, I only got just chest pain 2 hours ago, and I'm having a frothy sputum, or a pink sputum, I'm thinking about PE. So I want to get this patient, I want to investigate this patient for PE. So I'm going to ask this patient about the history of travel, where they have been immobile for some time, traveling on a bus, on a train, a flight, or they've been mobilized, or a major surgery in the past weeks, or they've been immobile at home, in bed, they've been bedridden, or they've been using oral contraceptives, things like that. So they've been, whether they've got swelling of the legs, they were diagnosed with DVT at some point, or things like that, or this pain is retrosternal, but it's worse when they are eating, things like that. So it's all about what do you know. When you take history, it's all about what do you know as a doctor. Because the patient can tell you anything and everything, but what do you know? Because they can tell you about a chest pain, and then they move away from the chest pain and start telling you about other things like dizziness, swelling of the legs, low abdominal pain, depending on nutrition. But they didn't tell you a lot about the chest pain. You don't know so much about the chest pain. So if you don't bring them back to the chest pain, you are going to entertain them depending on nutrition, dysuria, increased frequency, and diagnose a UTI. A UTI that is accompanied by a chest pain, and the chest pain is caused by something more dangerous than the UTI that you are diagnosing. So, because patients are not thinking the way we are thinking as doctors. So it's okay to tell you about depending on nutrition, it's okay to tell you about dysuria, but entertain the chest pain first and exhaust it and finish about it and move on to the other things. So let's say now, for instance, okay, I'm thinking this patient has got ischemic disease. Let's say the patient's got, I think this patient has got ischemic disease. That's my differential. So this is an internal medicine case at this point. So what am I going to do after taking that history? I'm not going to go and talk about obs and gynae. I'm not going to go and talk about surgical history there. I'm not going to go and talk about surgical social history. But what I will do, the next thing is going to be past medical history for my patient. And the past medical history that I'm going to specifically talk about is, I want to see, does this patient have any underlying medical conditions that will put her at risk of having ischemic disease, like hypertension, like diabetes, like dyslipidemia. So I always tell students that when you take history, you get to this part, you must always say what drugs are taken and what dose. Because if you say hypertension, I mean, someone who's taking Reduc 12.5 is different from someone who's taking 4 drugs, Reduc, amlodipine, enalapril, any other drug, but 4 drugs. It's different. The one who's taking 4 drugs, it shows that their disease progression, their disease has progressed much more than the person who's on a monotherapy, or this one has been diagnosed with hypertension longer, has been on this treatment for longer, or they are non-compliant, or they have got uncontrolled hypertension. So the person who's on 4 drugs is likely to develop target organ damage than the one who's on 1 drug, because of the reasons I've just explained. Maybe it's uncontrolled, things like that. So you need to know what dose are they. It's like, what drugs are they and what dose. It's like someone who's diabetic. If you're diabetic, I want to know, are you only on metformin 500 milligrams BD, or are you taking metformin and a sulfonylurea, whatever, Dionil, whatever drug, or are you on insulin? At least mention is on oral or is on insulin. It's very important. The one who's on insulin, probably their diabetes has progressed than the one who's on oral. Ne? So if they've got these, or they've got one of these, then I know these are risk factors for ischemic disease, the 3 of them. Ne? And then now I'm in internal medicine. So when I move from there, I'm going to talk about surgical history. From there, I am going to talk now about, if there's anything that I want to ask about obs and gynae, I will ask about that. When you prioritize history, it's not that you are leaving things out, but you are prioritizing which history is important. Yes, I will complete this, is okay. And then I'll talk about the social history. I'll talk about the habits. I'll talk about allergies, and then I'll review the systems. It's okay. And then when I go to examination, describe the patient, how the patient looks, and do the vital signs. And the system of interest in this case is cardiovascular. I'll do cardiovascular, I'll do respiratory, I'll examine the legs, and do my abdominal examination as well. And then CNS, and then I write my differentials, I do the investigations. This is internal medicine. Let's say now the same patient comes in with I want to show you something. The most important thing here is that when they give you the main complaint, quickly put differentials even before they can say anything there, and have them. And then as they keep speaking, you rule things out. As they keep speaking, you rule things out. And you might be left with 4 things or 3 things or 2 things. And then you get to examination, and then you are able to differentiate. Okay, no, actually it's not this, it's that. It's okay, it's fine. But what I'm trying to say is we shouldn't be taking history like robots that you just write to complete, to write everything because we can have a paper that is full. Be thoughtful as you speak to them. Think about, as you speak to them, have a differentials as you speak to them. There is nothing wrong having differentials from just the chief complaint only. There's nothing wrong there, because obviously you're going to listen to them and keep ruling them out up until you get to the end. What is important is chief complaint, associated symptoms, and then go and talk about past medical history, because your senior, once you say chest pain, they are itching to know what is this patient's past medical history. An internal medicine consultant, when you present to them, you say, I've got a chest pain, they are itching to know what other comorbidities does this patient have. They're not itching to know about obs and gynae history. They're not itching to know about surgical history. They are not itching to know about allergies of this patient. They want to know the other things are just gonna follow. I hope you get that. Now let's talk about a 45-year-old patient that comes in with PV bleeding. PV bleeding. With PV bleeding, yes, we are the duration, are there clots, change of pads, are there low abdominal pains, are they having any signs of hypotension like dizziness or headache, or which can also be signs of anemia, things like that, bleeding we're gonna ask about pregnancy, all those things, ne? The difference is when you get here with obs and gynae, when you think this patient is not pregnant, for instance, when you think the patient is not pregnant, I want to show you something, ne? let's say this patient, they come to they've got PV bleeding, and then they say they are pregnant, and then maybe they say the doctor said they are 30 weeks pregnant. So the way you write there, when the entry notes that you write is 45-year-old, because you would have checked their card, flipped through their maternity card, you see that they are pregnant, and then you see what's happening in their card. Normally what I do, when I see a patient that is pregnant, is carrying a booklet, that maternity booklet, I let them sit, and then I go through the file before I take history. I go through the file. When I go through the file, I check, okay, age, and 45-year-old, and then I check if they're G whatever, or P whatever, A whatever, at how many weeks, and then maybe I see that they are 33 weeks, or 30 weeks, as I said there. Okay, now your obs and gynae, your opening statements, they want this to be there. The second thing that they want to know about the RVD of the patient. Sorry, once you get here, they want to know they are 30 weeks. Is this by late ultrasound? Is it this by early ultrasound? Is it by dates? This 30 weeks that we're talking about. Then the next thing that they want is the RVD of the patient. And they want to know, are they on treatment? What's the CD4 count? What's the viral load? They want to know about the RH, and they want to know about the RPR of this patient. These are the things that you get from the file. And then I will begin to ask them, okay, why are they here? Then they'll say that I've got PV bleeding. So this is your opening statement in obstetrics. Opening statement. When you present to them, they are so itching to know, how old is this patient? What's the gravity of this patient? What gestation are they? And how was that determined? They want to know, is this patient RVD? Is this patient RH positive or negative? Is this patient RPR negative or RPR positive? Before you can start telling them about why did the patient come, that's your obs and gynae for you. And this is different from how an internal medicine is, the way I showed you. So now PV bleeding, passing clots, and then once you get here, they want to know about their gynae history, LNMP, how many days a cycle, dysmenorrhea, were they on contraception, for how long, menarche, all those things. And then obviously now you need to dwell more on your obstetric history, which is like, now it's so what happened to this other pregnancy now? Was it an NVD? Was it a Caesar? Which year was it? What was the indication for a Caesar? Then you come to past medical history. They are not really interested about the past medical history. What they want is these things. But you need, because there might be conditions that the patient might be having, like someone who's pregnant but they've got a cardiac problem, pregnant but they are diabetic. But what the priority in your history taking is this first two. So you do your past medical history, surgical history, then you do your allergy, social history, habits, all that. You're going, and then when you examine them, describe how they look, vital signs, abdominal examination, PV examination, and then the other systems will follow. Now, with a pure gynae patient who is not pregnant, it also differs. It's not really, okay. So 45-year-old female, they are not pregnant now, so there's no problem. There's no reason to put this. So just present them like that, PV bleeding, and then you begin to tell about all the associated symptoms, the other things that they are having. You dwell more on the PV bleeding, and then you do your gynae there. You do your obs history, you do your past medical history, just like here. So this is how you clock a gynae patient. This is how you clock an obstetric patient. That's the difference. Let's talk about a pediatric patient now. How do you clock a pediatric patient? when you are in PIDS, this KIDI, okay, maybe let's do this on another video so that we don't have a long video. Thank you for watching.